In our today's discussion at Medical Sciences, we are going to look at blood transfusion reactions. Previously, we have looked at compatibility tests that are performed to ensure that the blood is safe for medicinal use. But today we are looking at, in case there is any error or anything that has gone unnoticed, what could be the probable cause of that reaction, and how can we investigate it in the laboratory? And then we shall also go ahead to look at the management. How do we manage that patient who has got transfusion reaction due to blood group or products incompatibility? But as we begin, we are going to look at what are the do's when transfusing blood to prevent these reactions. The dose is that the blood should always be warmed at 37 degrees, should always be warmed at 37 degrees to attain body temperature. Then the nurses who are picking blood to be transfused should always check for the labeling and the patient identification to make sure that the donor blood is given to the right patient. And while infusing, they should always make sure to use the needle of a large bore size. The needle, the gauge should be, the best is 18 gauge, or if you don't have 18 gauge, you can use 19 gauge. So this is the most appropriate, the 18 gauge needle, while transfusing. And when you are transfusing this patient, it is recommended to give 2 mils, to make sure that you run 2 mils per minute. So this is the infusion rate. So avoid high infusion, so you should make sure the infusion rate is at 2 mils per minute after using an 18 needle gauge. And after the transfusion has begun running, make sure you keep monitoring the patient for the first 15 minutes. For the first 15 minutes, the nurse should remain at the bedside monitoring the patient. And what do you monitor? The temperatures. You record the temperature before transfusing, and within 15 minutes, at interval of 5 minutes, you keep monitoring the heart rate, the blood pressure, and the temperature. That is in the first 15 minutes. Then after 15 minutes, you can check again after 30 minutes. Then afterwards, you can do it after 1 hour. After 1 hour, you monitor to see if there is any reaction that is going to occur. And before transfusing this blood, never forget also to check for the expiry date. In case the lab people during compatibility, they never noticed it, you can easily identify it. So that is what we can do. So this one leads us to what we are in our session of today, which is the blood transfusion reactions. And these blood transfusion reactions, they can be immediate, they can occur during or immediately after. So those ones we call them immediate blood transfusion reaction. But there are those which we call delayed. The immediate occur within 24 hours. Then the delayed is after 24 hours. But majorly it takes 7 days. So they can either be immediate or delayed. This one is about onset of the reaction. But as we go on, we are going to see that these reactions are categorized into major groups. Apart from being immediate and delayed, they are categorized into major groups, whereby these reactions, the reactions, they can either be non-hemolytic, they can be non-hemolytic, or they can be hemolytic. And under non-hemolytic, these are majorly immediate, and they include reactions under non-hemolytic include febrile reactions, include allergic reactions, and these febrile reactions, this is allergic reactions. So these are the major two non-hemolytic reactions. Then under hemolytic, they are also further categorized into two. They are further categorized into two, whereby they can either be intravesicular, they can be extravesicular, or they can be intravesicular. So these are the blood transfusion reactions. Today we are looking at the unfavorable. We are looking at unfavorable reactions. Unfavorable reactions that occur during blood transfusion. And these ones, they occur on the recipient. They can occur on the recipient or on the donor. So these are the unfavorable reactions we are looking at, when the blood given is either incompatible or it is due to clerical errors. But the leading cause of these reactions is clerical errors, or either patient misidentification, mislabeling, and so forth. Long recording of the results they are the one that result into this. So we are going to say that the intravesicular hemolytic reactions, these ones, it is due to lysis or destruction of red cells, and hemolysis can either occur inside, outside the blood vessel. It can occur outside. That is what we are calling extravesicular. And this outside the blood vessel, it is the destruction is occurring in the reticuloendothelial system. That is the spleen, liver, and bone marrow. So the macrophages within the reticuloendothelial system, they destroy the red cells passing through them. And the major cause of extravesicular hemolysis can be due to incompatible blood group. It can be infusing at high temperature, or presence of antibodies that are destroyed, that are targeted against. Then another type is intravesicular. Intravesicular means it is occurring inside the blood vessel. Inside the blood vessel. So the destruction of cells is occurring inside the blood vessels. And when it occurs inside the blood vessels, it is either due to incompatible blood, due to clerical errors, or due to miscross-matching, or it can be due to presence of antibodies, rare antibodies, in the patient's or recipient's serum, which are destroying donor cells. And these antibodies, they have ability to activate the complement. They activate the complement system, leading to cell lysis. So this is what we are calling intravesicular. And how do you distinguish that the hemolysis or destruction of red cells after transfusion is either extravascular or intravascular. In extravascular, this one is characterized by jaundice, by the onset of jaundice, that is yellowing of the scalar membranes. But this, for intravascular, it is characterized by presence of hemolysis in plasma, presence of hemolysis. After observing plasma, which appears red in color, we can also see hemoglobinuria. Hemoglobinuria, presence of free hemoglobin in urine. So these are the signs of either extravascular or intravascular hemolysis. And we have seen the common causes can be incompatible blood group due to misidentification of the patient, mislabeling, failure to review previous records of the patient. We can even other causes of this can be high rate of infusion, high infusion rate. That is giving the blood using either a needle of the small gauge at a faster rate. Can also cause that. Also giving expired donor blood, using expired donor blood, giving hemolyzed, already hemolyzed donor blood can also lead to hemolysis. These are other causes of hemolysis. Another cause of hemolysis can be due to iron overload. And this iron overload is brought about by continuous transfusion, can lead to this. So these are some of other causes of this hemolytic type, because we said we are dividing them into two, whereby A was for non-hemolytic and B was for hemolytic. So we have expounded on the hemolytic, which we have further categorized them into two, intravascular and extravascular. Allow me also to talk about the non-hemolytic a little bit. The non-hemolytic transfusion reactions, which we have seen. So these are unfavorable reactions, those are, which do not involve destruction of red cells. So under non-hemolytic, here there is no cell destruction. There is no cell destruction, but the reactions are observed or are seen which lead to difference. And one of them is the febrile reactions. And these febrile reactions, they occur. These are immediate. Sometimes they are majorly immediate, which occur due to the patients who are deficient of IgA antigens. So patients who lack IgA antigens, they tend to react to IgA antibodies in the serum. So these reactions, these febrile reactions, excuse me a little bit, this is not due to the deficiency of this. This is not due to their deficiency. These febrile reactions, they are caused by incompatibility of leukocyte or platelet incompatibility. These are antibodies, leukocyte or platelet antibodies, that when you infuse a patient of donor cells which contain antibodies which are incompatible, can lead to these febrile reactions. And these reactions are always characterized by presence of fever. We see fever coming in, presence of chills and back pain, but majorly chills and fever. Why fever and chills? They trigger production of cytokines, like interleukins, which trigger increase in fever, and cortisol is increased by +1 degrees centigrade. So this is due to the leukocyte or platelet incompatibility, whereby the antibodies are directed at destroying white blood cells and platelets. That is what we are calling febrile reactions, and we say these reactions are immediate. They can occur during or immediately after transfusion. Then the allergic reactions, these are the ones which occur in IgA antigen deficient patients, whereby the antibodies against IgA react, and when they react, they lead or they stimulate production of IgE antibodies. And these IgE, they bind, if this is a mast cell, they bind using the Fc portion binding on the mast cell, and when they bind on the mast cell, they lead to the production of inflammatory mediators like histamines, prostaglandins, platelet activating factors. These are the inflammatory response that brings about hypersensitivity reactions. These ones bring about hypersensitivity, especially type 1, which will occur as urticaria. And this urticaria is characterized by signs like itching, phlebitis, but majorly it is always itching and rash and itching. That is, it indicates presence of allergic reactions due to deficiency of IgA antigens, whereby proteins or antibodies in the serum of the patient are reacting against them, causing these allergic reactions. These ones can be treated by giving corticosteroids like prednisolone can be given, and cortisone. Then here, where there is fever and chills, you can treat by giving antipyretics like paracetamol or NSAIDs to treat the fever. So this is what we can, but majorly antipyretics like paracetamol. Then here corticosteroids are given to prevent this reaction, this allergic reaction, hypersensitivity type 1, which we are calling urticaria. So this is what we can discuss about the causes or the types. We have looked at the types and their specific causes, whereby in summary, as a student, we have seen that they are categorized into two, that is non-hemolytic and favorable reactions, whereby under non-hemolytic there is no destruction of cells. And they include febrile, which are due to leukocyte or platelet antibodies. These antibodies, they are the one that cause antigen-antibody reactions, which brings about fever and chills. And these fever and chills are due to production of cytokines like interleukins. Then we have said it can be treated by giving antipyretics like paracetamol. Then with allergic reaction or hypersensitivity type 1 reaction is due to the people who are deficient of IgA antigens, which cause antigen-antibody reactions, which trigger production of IgE that bind on the surface of basophils and mast cells, leading to production of inflammatory mediators like histamines and prostaglandins, which can be characterized by itching and rash, and we have seen we can treat them by giving corticosteroids to prevent these inflammatory reactions. Then the part B is the hemolytic blood transfusion reactions. These ones are characterized by hemolysis or destruction of red cells, which we have seen they can either be extravascular or intravascular. Extravascular occurring in the macrophages in the reticuloendothelial cells, leading to destruction of red cells which is characterized by jaundice, then intravascular, occurring inside the vessels due to activation of the complement system, which destroys the cells. And the major cause can be a compatible blood group or presence of rare antibodies that can activate the complement. And we saw other causes can be high infusion rate, using expired donor blood, using hemolyzed blood, and iron overload, and so forth. So these are the things we have discussed about. So after discussing about this, now we have to look at the investigations. How do we investigate all these things we have talked about? How do we rule out them in the lab? So in the laboratory, we're going to look at investigations or lab diagnosis. How do we investigate the possible or the probable cause? Is it either non-hemolytic? Is it hemolytic? So how do we investigate in the laboratory? And the specimens or the sample which we use in the laboratory, the first thing, if these transfusion reactions occur, the first thing you do as a bedside nurse is to stop immediately the transfusion. You stop the flow of blood immediately. And after stopping, you look at managing these signs and symptoms as you call the doctor. And as the doctor comes, they are going to request for samples to be taken off. And these samples include, we shall collect a post-transfusion reaction sample. We shall also, and this post-transfusion reaction sample, we collect both blood and urine. Collect blood and urine from the patient after the reaction has occurred. Then another sample we shall also use the pre-blood transfusion reaction sample. We shall need it still. We shall also need donor unit, donor blood, also to do some investigation. So these are the samples which we can use. These are the samples we are going to use in investigating blood transfusion reactions. After getting these samples, the first thing we do in investigation, the first thing after getting the samples, the first intervention is proper identification. Here, we are looking if there was no clerical errors. So here, we said the major cause is due to misidentification and mislabeling. So here we first rule out clerical errors. Clerical errors that might have happened due to either misidentification of the patient, can be mislabeling of the donor blood, can be due to either wrong recording of the cross-match results. So here we are checking for any possible error. Was there misidentification of the patient or mislabeling? Maybe it was blood group A, then you gave B. Or was there a wrong recording of the cross-match results? That is the first thing we do. After doing this as the first thing, the next thing we are going to do is we are going to do regrouping. So we do regrouping using pre-transfusion, pre-blood transfusion reaction sample, blood sample, and on this we also use the donor blood, and here we are going to repeat ABO and rhesus grouping. We repeat all of them on the pre-transfusion blood sample. After repeating this, we can go ahead and we also repeat cross-match. We repeat cross-matching. We repeat blood cross-match, and this one can be done using both pre-blood transfusion reaction and post-blood transfusion reaction sample. We use both and repeat cross-match to see if maybe the mistake would have been from cross-match errors. And during cross-match, remember, we use the serum. Here we use serum against donor cells, 5% donor cells, and we rule out any presence. Then D, we can go ahead and we perform direct Coombs, direct anti-human globulin test, or what we call direct Coombs test, to rule out the presence of sensitized cells. If there is presence of sensitized cells after transfusing the patient. So we do direct Coombs. Then on this post-blood transfusion sample, we can go ahead on the post-transfusion sample, we can go ahead and we observe for presence of hemolysis. We look at it. Is there any presence of hemolysis? By centrifuging, and we look at the plasma color. If it is red in color, it means there is maybe hemolytic transfusion reaction. We can go ahead and look at the post-transfusion urine sample, and we observe for presence of hemoglobinuria. Presence of free hemoglobin in urine. We can also do that. On this, the same sample of this patient, post-transfusion, we can perform a thin film. And the thin film, we are going to look for presence of schistocytes in a thin film or spherocytes. So presence of schistocytes, those are fragmented red cells, and the spherocytes implies intravascular hemolysis. Then for urine, presence of hemoglobinuria also indicates intravascular hemolysis. So these are the tests that we perform during investigation. Then after 6 hours, after the onset of blood transfusion reaction, we can also collect another post-blood transfusion reaction sample. And on this sample, we are going to determine HB levels and blood count. We do blood count and HB levels. And at the same time, we can also do bilirubin level determination. Bilirubin level. In case of jaundice, we are going to determine bilirubin levels, and if we find an conjugated type is high, then we can think of extravascular hemolysis due to destruction of cells in the reticuloendothelial system. So these are the lab investigations that are performed. In summary, we have seen we need the post-blood transfusion sample and urine sample, and on the blood sample, we are going to perform a thin film. We are going to check for the presence of hemolysis and so forth. Then on the urine, we are looking for the presence of free hemoglobin in the urine. Then we repeat the grouping, both the ABO and resus, to see if there is compatibility on both the patient and the donor. We do repeat the cross-match, both on the pre and the post. Then we also do direct Coombs throughout presence of rare antibodies or incomplete antibodies in patient's cell that would have sensitized the cell, which might be triggering the reaction. Then we also we collect another sample after 6 hours to do blood count, to look at the HB levels and to look at the bilirubin levels. We can even go ahead and we look at the haptoglobin levels. haptoglobin. And if the haptoglobin levels are reduced, it also implies intravascular hemolysis. So these are the interventions that we can always do in investigation of blood transfusion reactions. Hope you have gained a lot from this presentation. Always keep learning from us, recommending many people to learn at Medical Sciences Made Easy by Naftali Muhumuza. God be with you.